Now, we are going to start with endocrinology. This is a pretty simple chapter, so we'll go through it as soon as possible. The first one is going to be about the anti-diabetic drugs. These are the drugs used in diabetes. Now, diabetes, we know there are two types, type 1 diabetes mellitus, type 2 diabetes mellitus. In type 1 diabetes mellitus, there is autoimmune destruction of beta cells of pancreas. So, there is no release of insulin. So, what should be the treatment? You have to give insulin. How can you give insulin? Through subcutaneous route. But what is the most common site of administration of insulin? This is going to be in the abdomen. Now, what are the types of insulins that you know? See, according to the textbooks, there are only two types, short acting and long acting. But I've divided into 2 to 3 groups. Let us see how. Short acting you have Lispro, Aspart, Glulicin as well as regular insulin. But Lispro, Aspart, Glulicin are fast acting, regular insulin is slow acting. This is how I divided it. Now, coming into the long acting, I've again divided into two, intermediate and long acting. See, in intermediate acting, NPH and Lentil. In long acting, you have Detamir, Glargine and Degludec. The longest acting insulin is Degludec. Now, we also have a ultra fast acting insulin, that is what is nasal insulin. It is Afrezza. This is the latest insulin. Got it? Where is this regular insulin used? This regular insulin is generally used in type 1 diabetes mellitus. Yes, and it is also used in diabetic ketoacidosis. It can also be used in pregnancies. It can also be used in pregnancies. Yes. Now, what are the side effects of this? Obviously, when you give insulin, sugar levels are going to decrease. This will cause hypoglycemia. Yes, along with glucose, potassium will also go inside the cells. So, potassium in the blood will decrease. That is what is known as hypokalemia. And it can also cause lipodystrophy. Lipodystrophy. That is the reason why you have to alternate the sites of injections with insulin. Now, coming to the type 2 diabetes mellitus, the problem here is insulin resistance. The problem here is insulin resistance. So, here we can give two types of drugs. One that is increasing the secretion of insulin. The others are drugs acting via other mechanisms. So, first group, before seeing this first group, so let us see when you are having food what happens. Yes, see, you are having a meal. So, this meal comes into the small intestine, and when this glucose and the meal is in the small intestine, it will stretch the intestine. Yes, when this stretches the intestine, what will happen? It will release GLP-1 and GIP. GLP-1 and GIP. As you already know, in the pancreas, we have beta cells. They will have receptors for GLP-1 and GIP. So, what will this GLP-1 and GIP do? They will act on their receptors and it will cause production of insulin. It will cause production of insulin. Now, what will the insulin do? Insulin will act on the cells and it will cause expression of GLUT4 receptors. Usually in the cells, GLUT4 receptors are present inside, but when insulin acts, it will cause GLUT4 receptor. When insulin acts on the cell, it will cause GLUT4 receptor expression. So, what will happen now? This glucose will be absorbed into the blood. Yes, and from the blood, it will be taken into the cells via this GLUT4 receptor. Why is all of this happening? It is because of the insulin release. But how is insulin released? Because of stretching of intestine. Now, this will release GLP-1 and GIP. So, did you understand this? So, if you give GLP-1 analog, will it release insulin? Yes. If you give GIP analog, will it release insulin? Yes. So, these are the drugs that are releasing the insulin. So, this is what is happening in the postprandial period. Postprandial period. Now, what is happening when the person is not eating anything? How is basal insulin released? How is basal insulin released? See, about this, I've talked so many times in the classes and I've also made a small Instagram reel and YouTube clip on this. You can watch this quickly. Yes, you will see the mechanism of action of sulfonylureas and meglitinides, and you also see how the insulin is released. So I'm not going to repeat it because it has been done so many times. So drugs that is increasing the release of insulin. What are these drugs? I've already told you. You can give GLP-1 agonist. These are glutides. Liraglutide, albiglutide, dulaglutide and semaglutide. These will cause weight loss. Now, if you see, GLP-1 is metabolized by something known as DPP-4. If you see, GLP-1 is metabolized by something known as DPP-4. So if you block this DPP-4, will GLP-1 increase? Obviously, that is why the other class is DPP-4 inhibitors. These are gliptins. Which gliptins? Sitagliptin, vildagliptin, dapagliptin and linagliptin. Now, all the gliptins are not safe in renal failure except linagliptin. Linagliptin is renal safe. This is what I want you to remember. Linagliptin is renal safe. Now, we have one more thing, that is GLP-1 and GIP agonist. It is having dual action. This is what is tirzepatide. It is having tirzepatide. Two actions, so tirzepatide. T for 2. Got it? So that's all. About the sulfonylurea and meglitinides, I've already asked you to watch that reel where I've explained everything very carefully. Yes, these will block the ATP dependent potassium channels. So it will release the insulin. Now, in sulfonylureas, first generation are chloropropamide and tolbutamide. It has lot of side effects, so not generally used. Coming to the second generation, these are glyburide, glimepiride and glycoside. Yes, glyburide, glimepiride and glycoside. Now, meglitinides are neteglinide, repaglinide. So you will see the name glinide in their names. Did you understand this? This is the first class of drugs that increasing the release of insulin. Now, I have already written here sulfonylurea's first generation is chloropropamide. Now, what are the side effects? It will increase ADH, but most important is it will cause disulfiram-like reaction. What about tolbutamide? It follows zero order kinetics. Tolbutamide, it follows zero order kinetics. Now, coming to the other class of drugs. One is alpha glucosidase inhibitor. Alpha glucosidase inhibitor. When you're having a meal, obviously you'll have complex carbohydrates like starch. Starch has to be converted into simple carbohydrates. How is this happening? With the help of alpha glucosidase. Now, if you block this, this starch will not be converted into simple glucose, so it will not be absorbed into the blood. So what will happen? This starch will come directly into the gut. So gut bacteria will eat up this starch and it will cause flatulence. Yes, it will cause flatulence. Since starch is osmotic, it will also pull the water along with it and it will cause diarrhea. This is known as osmotic diarrhea. This is known as osmotic diarrhea. Since it is glucosidase, the drug names are acarbose, voglibose and miglitol. Acarbose, voglibose and miglitol. Then you have a amylin analog, that is pramlintide. Next is thiazolidine diones. Now, they will activate PPAR gamma receptor. The drug names are glitazones, rosiglitazone and pioglitazone. So, what are the side effects? Pretty common mnemonic. Rosi breaks your heart, so it is cardiotoxic. Some glitazones will also cause bladder cancer. Next are biguanides. Biguanides means metformin. Now, metformin is the drug of choice in type 2 diabetes, as all of you know. What are the side effects that you can see with metformin? You can see acidosis, lactic acidosis. Sometimes it can also cause a megaloblastic anemia. Yes. Now, SGLT2 inhibitor, we have discussed so many times in CVS also. I told these are gliflozins. Along with sodium, glucose will also flow in the urine. So, glucose levels in the body will decrease. Dapagliflozin, empagliflozin and canagliflozin. What are the side effects? Because glucose is in the urine, it will cause UTI. And sometimes it might also cause bone fractures. Yes, that's all. So, there are some drugs that are causing weight loss. I have already told you about one of them. That is GLP-1 analog. It will cause weight loss. Amylin analog, pramlintide. Metformin, yes. SGLT2 inhibitors, it will cause weight loss. How can you remember this? When you play games, you will lose weight, isn't it? So, this is how you can remember. GLP-1 analog, amylin analog, metformin and SGLT2 inhibitor. Now, GLP-1 along with GIP is tirzepatide, that will also lose weight. Got it? Weight gain. Whenever there is release of insulin, it will cause weight gain. Sulfonylureas, it will release insulin. Yes. Insulin, yes, it will cause weight gain. Thiazolidine diones will also cause weight gain. So, how can you remember? If you sit, it will cause weight gain. Yes, that's all. Sulfonylureas along with meglitinides. Meglitinides will also release insulin. So, this will also cause weight gain. That's all. Now, what are causing the hypoglycemia? When insulin is released, it will cause hypoglycemia. What are releasing insulin? Sulfonylurea and meglitinides along with insulin. They will cause hypoglycemia. That's all. Pretty simple. Now, coming to the chapter of growth hormone. Growth hormone, if it is decreased, it will cause dwarfism. Increased, it will cause acromegaly. So, if growth hormone is decreased, what is the treatment? You have to increase the growth hormone. So, first we will see there is something known as growth hormone releasing hormone analogs. These are morelin, sermorelin, massimorelin, tesamorelin. Yes, sermorelin, massimorelin, tesamorelin. Next are growth hormone analogs. They look exactly like growth hormone. So these drugs are somatram and somatropin. What are the side effects? If growth hormone increases, it will cause carpal tunnel syndrome and hyperglycemia. Carpal tunnel syndrome and hyperglycemia. Yes. Next is IGF-1 analog. It is insulin-like growth factor 1 analog. What are the drugs? Mecasermin. What is mecasermin rinfabate? It is IGF-1 plus IGF binding protein analog. Yes, what is the side effect? Because it is insulin-like growth factor. What will insulin cause? It will cause hypoglycemia. This is what I want you to remember. IGF-1 will cause hypoglycemia. GH will cause hyperglycemia. Next, coming to the acromegaly. Acromegaly means growth hormone is increased. How can you decrease the growth hormone? By giving somatostatin. Yes, why? Because it is a growth hormone inhibiting hormone, somatostatin. Yes, now, what are somatostatin analogs? Octreotide, lanreotide and perisereotide. It is given in the name. Somatostatin is octreotide, lanreotide and perisereotide. What are the uses of octreotide or somatostatin analogs? Somatostatin. See, somatostatin, SOMA, these are the uses. S for secretory diarrhea, O for esophageal varices, M for malignancies, A for acromegaly. That is why we are using it in acromegaly, isn't it? Now, why is it used in malignancy? Because it will decrease both insulin and glucagon. Now we have a growth hormone receptor antagonist, that is what is known as pegvisomant. This is used in resistant acromegaly. Okay. Now coming to the posterior pituitary gland, what are the hormones that are released from the posterior pituitary gland? Oxytocin and dopamine. So oxytocin is drug of choice for augmentation of labor. At least this much you know. Augmentation of labor, postpartum hemorrhage, and in breast engorgement also you can use oxytocin. Okay. Now dopamine agonists are bromocriptine and cabergoline. These are drug of choice in hyperprolactinemia. Very important. Even though these are two lines, please remember it. Hyperprolactinemia, bromocriptine and cabergoline. Now, coming to the thyroid gland. Pretty simple. Thyroid gland. Thyroid hormones are increased. That will cause hyperthyroidism. In hyperthyroidism, we will use drugs like thioamides. Thioamides are TPO inhibitor. Thyroid peroxidase inhibitor. What are the drugs? Carbimazole and methimazole. Carbimazole is a prodrug. It is converted into methimazole. Now, what is the drug of choice for hyperthyroidism? Obviously, it is this drug carbimazole and methimazole. Now, can you use this drugs in the pregnancy? No. Why? Because it has a side effect. It has a side effect called aplasia cutis. Aplasia cutis, and it can also cause conal atresia or esophageal atresia also. Conal atresia and esophageal atresia also. These are teratogenic effects, no? So you cannot use them in pregnancy. So in the first trimester of pregnancy, you should use propyl thiouracil, PTU. So it is given P for P, पहले trimester. पहले trimester में क्या use करना चाहिए? It is PTU. So drug of choice for hyperthyroidism in first trimester is PTU. Will you continue for the second and third trimester as well? Because it is having less teratogenic effects. No, you should not continue. Why? Because this is hepatotoxic. So you will use it only in the first trimester, but again in second and third you will use carbimazole, methimazole. Why? By the second and third trimester, organogenesis is mostly done. That is why we can use it in second and third trimester. Now, next drugs are secretion inhibitors. These are 5% Lugol's iodine and 10% potassium iodide. These are fast-acting antithyroid drugs. Yes, so they can be used before surgery to decrease the vascularity and the size of the gland. This is about the Lugol's iodine and potassium iodide. Now, coming to thyroid storm. In thyroid storm, you will have atrial fibrillation. If you remember atrial fibrillation, I told you for rhythm control and rate control, I told you drugs. For rate control, what are the drugs we are using in atrial fibrillation? Beta blocker, calcium channel blocker, and digoxin. That is why the drug of choice here is beta blocker. But if they ask you anti-thyroid drug of choice for thyroid storm, it is going to be PTU, propyl thiouracil. It is going to be PTU, propyl thiouracil. Let us suppose a person is having hypothyroidism. That means thyroid hormones are reduced. What you should do? Thyroid hormone replacement. Okay, leothyronin is T3, levothyroxine is T4. So this is the drug of choice in hypothyroidism. This is the drug of choice in hypothyroidism. That's all. Now, adrenal gland secretes cortisol, steroids. Yes, cortisol is steroid. So, you know many steroids that will cause inflammatory disorders. Okay. What are the uses of steroids? See, main use I want you to remember is it is used for surfactant maturation in preterm labor. Now, what is the dosing for this? You have to give 24 mg in 48 hours. 24 mg in 48 hours to the mother. Now, we can give two steroids. What are they? B and D. Betamethasone, dexamethasone. Since betamethasone is a second letter, see here betamethasone. It is second letter, you will give 2 doses. Dexamethasone is fourth letter, so you will give 4 doses. So, if you have to give 24 mg in 2 doses, what will be the betamethasone dosing? It is 12 mg, 2 doses, 24 hourly. Now, coming back to dexamethasone, if you have to give 4 doses, it should be 6 mg. Yes, 6 mg, 4 doses, you have to give 12th hourly. That will make it 48 hours. Understood? That is about betamethasone and dexamethasone. Now, what are the side effects of this? It will cause centripetal obesity. It will also cause proximal myopathy. That is what gives you lemon on stick appearance. So, basically, if you use steroids for a long period of time, it will cause Cushing syndrome. And it will also cause diabetes mellitus, osteoporosis, and severe use of steroids for a very long period of time will cause avascular necrosis. It will also cause hair loss, and in the eyes, this is important to remember, it will cause posterior subcapsular cataract. Posterior subcapsular cataract. Yes, chloroquine also causes this. Chloroquine also causes the vortex keratopathy or cornea verticillata. Yes, posterior subcapsular cataract. Please remember this. Yes, now, if you use steroids for a long period of time, it will suppress the HPA axis. So, to prevent this, what you should do? You should use low doses of steroids when possible. If not, if you are using high doses of steroids, when you are stopping, you should taper the steroids. You taper the dose of steroids and then stop. Yes, that's all. Now, coming to osteoporosis. Osteoporosis, what could be the treatment? You can either block osteoclast or you can activate osteoblast. Now, how do you block osteoclast? With the help of drug called bisphosphonate. So, you see here bisphosphonates. These are dronate drugs. Alendronate, risendronate, zolendronate. Zolendronate is IV. Now, it is blocking the osteoclast by causing apoptosis. Apoptosis means death. What are the side effects? It will cause osteonecrosis of jaw and dronates. AIDS means these are acidic drugs. So, if they are in the esophagus, it can cause esophagitis. So, how do you prevent it? How do you prevent it? You should ask the patient to take the tablet with full glass of water. Full glass of water. And you should ask the patient not to lie down at least for 30 minutes. Don't lie down at least for 30 minutes. Why? 30 minutes is the gastric emptying time. By 30 minutes, the drug might have passed from the gastric into the small intestine. So, it will not come back. Yes, preferably on empty stomach. If the patient is on empty stomach, it would be even better. Now, PTH analog is teriparatide. It will activate the osteoblast. There is one more drug, strontium granulate. It will block osteoclast and it will activate osteoblast, but it is not used because it has lot of side effects. It has lot of side effects, many side effects. Yes. So, now we will start with the drugs acting on the reproductive system. First, we will see the female reproductive system drugs. Yes, these are going to be GnRH analogs. Now, when gonadotropin releasing hormone is released, it will act on the pituitary gland. It will release LH and FSH. This much you already know. Now, what is GnRH analog? That is gonadorelin. Now, we can give GnRH agonists. What are these? Goserelin, buserelin, histarelin, nafarelin and leuprolide. Gonadorelin is GnRH analog. GnRH agonist is relins. Goserelin, buserelin, all these relins. Okay. Now, here listen carefully. If GnRH, yes, how is it released in the body? Pulsatile. When it is released in a pulsatile manner, it will increase LH and FSH. That much you already know. So, if you give GnRH agonist in an intermittent dosing, it is similar to pulsatile, no? So, it will increase LH and FSH. Yes, that's all. That is why it is used in delayed puberty. Now, if you give continuous dosing, what will happen? First, it will increase LH and FSH, but after a period of time, continuous stimulation of receptors will cause receptor down regulation. So, it will reduce the LH and FSH. So, if you are given a continuous dosing, in the long term, it will reduce LH and FSH. That is why it can be used as a GnRH antagonist as well. Yes, so it is used in precocious puberty, endometriosis, fibrosis and ER-positive breast cancer. But the problem here is, it will cause a flare-up reaction. Let us suppose a person is having pain because of endometriosis. If you give GnRH agonist in a continuous dosing, first the pain will increase because LH and FSH is increased and it will increase the estrogen, but after some time this will decrease. That increasing in pain is what is known as flare-up reaction. To prevent this, we have made GnRH antagonists. These are Abaralex, Cetrorelix, Dagarelix and Ganirelix. Yes, now we also have a tablet that is Elagolix. Elagolix. That's all about the GnRH analogs. Now coming to the estrogen compounds, we have something known as SERMs. Selective estrogen receptor modulator. Yes, because estrogen is present in, estrogen receptors are present on many organs. Yes, you want to increase or decrease the effect in certain organs. That is why we have made SERMs. Yes, so in this I want you to remember tamoxifen, raloxifene and clomifen. Next is SERD, selective estrogen receptor down regulator, that is fulvestrant and elacestrant. Next is aromatase inhibitor. What is aromatase inhibitor? See, in postmenopausal females, testosterone is converted into estrogen with the help of an enzyme called aromatase. So, if you block this aromatase, estrogen will not be formed. All of these are anastrozole and letrozole. Now, I want you to remember these drugs, that is fine. But what are the uses of these drugs? We will see. See, if a person is having ER-positive breast cancer, if a woman is having ER-positive breast cancer, and if the woman is premenopausal, which drug would you use? Tamoxifen. If the female is postmenopausal, you would use letrozole. Now, suppose the woman is a postmenopausal woman with ER-positive breast cancer and having osteoporosis, that is when you use raloxifene. That is where you will use raloxifene. These are the uses of these tablets. Okay. Now, coming to PCOD. PCOD, the woman has irregular cycles. The drug of choice for irregular cycles are OCP. She will also have insulin resistance. The drug of choice is metformin. She will also have anovulatory cycles. Because of this, it will cause infertility. Now, which drug will you use here? It is supposed to be letrozole. Yes, now, coming to the anovulatory infertility without PCOD. She has anovulatory infertility, but this time she does not have PCOD. Here you can use clomiphene. Now, short words about contraception. For contraception, you can use combined OCPs, progesterone only pills, or for emergency contraception, you would use levonorgestrel, that is, has to be used within 72 hours. Now, there is one more drug called ulipristal that can be taken within 5 days. Now, in progesterone, I just want you to remember one drug, SPRM, selective progesterone receptor modulator, that is mifepristone. Mifepristone will block the progesterone receptors in the endometrium. That is why it is the first line drug in abortion. So, if you want to cause abortion, you will give mifepristone. Mifepristone will cause detachment of the embryo from the uterus. Yes. Now, Then you give misoprostol. What will misoprostol do? It will do contraction of uterus and the embryo will come outside. Did you understand this much? This is about the abortion. This is what is done in the first trimester abortion. Yes, that's all. These are the uses I want you to remember.